Imagine you just found out that you're pregnant and you're working 2 hourly jobs. You're doing everything you can to make ends meet, but your employer doesn't offer health insurance, and you can't just take it just takes too much to qualify for traditional year-round Medicaid. But now you're pregnant and you want to do exactly what you're supposed to do. So you call your local health clinic to schedule your critical first trimester checkup. But the receptionist on the other end of the line stops you. She tells you that without an active insurance policy, it's going to be at least $200 out of pocket just to walk through the front door. You don't even have $200 to spare this week. So you sit down at your kitchen table and you gather your pay stubs and you apply for pregnancy related Medicaid, and then you enter the bureaucratic black box. By federal law, state Medicaid agencies have up to 45 days to process your application. That is actually a month and a half. So when you're pregnant and waiting for 45 days for basic medical care, it isn't just an inconvenience. This is actually a pretty big issue and a massive clinical risk. The first trimester foundational window of fetal development. So this is when organogenesis happens, or the formation of the baby's organs. If you're forced to wait 45 days on the clock, we as healthcare providers miss the chance to do a baseline ultrasound. We miss the chance to detect a potentially life-threatening ectopic pregnancy. We miss the chance to identify and manage chronic hypertension, which can easily spiral into preeclampsia later on. And we delay your access to prenatal vitamins and folic acid, which are absolutely critical for preventing neural tube defects. So every single week of pregnancy counts. But right now, millions of mothers are stuck behind a 45-day velvet rope, waiting for a piece of paper to tell them that they're finally allowed to see a doctor. So think of the healthcare system like you're trying to get into the healthy baby theme park. Inside, there's everything a pregnant mother needs: routine checkups, lab visits, ultrasounds, screenings, peace of mind, care coordination. The list goes on and on. These are all the things that you need. But there's a massive, unmoving line at the ticket booth. The sign above the booth says, application processing 45 days, because you know it's going to take all 45 days. Now, if a park guide walked up to you in line and asked you three basic questions, snap a VIP fast pass around your wrist, what would you do? Because that VIP fast pass is just like the fast passes at every theme park that you can imagine. So that means that you don't have to wait. You get to skip the line, you get to walk through the gates, you get to see the doctor today. Meanwhile, the people at the ticket booth can take all the time they need to process your official permanent paperwork on the back end. That means you get in. You get in. You start receiving the care that you deserve, the care that you need, and on the back end, everything else is being taken care of, vetted, checked, because time is of the essence. So the VIP Fast Pass actually exists in the real world. It's a Medicaid policy called Presumptive Eligibility. It allows for immediate, same day access to prenatal care. But here's the catch: whether or not you can get this depends entirely on your zip code. Before we dive into the map and see which states are failing their mothers, we need to understand the sheer scale of this issue. This isn't a niche policy that only affects a tiny fraction of the population. In fact, according to the CDC and Kaiser Family Foundation, Medicaid finances over 41% of all births in the United States. That's nearly half of all babies born in the country. And if you zoom in to rural America, that number jumps closer to 50%. We're living in an era of maternity care deserts. Across the country, rural hospitals are closing their labor and delivery wards at an alarming rate. Mothers are already having to drive an hour or more to find OBGYN care or even a midwife. So when you combine a physical lack of clinics with a 45-day administrative hurdle at waitlist, you're building an insurmountable wall between mothers and the care that the mothers actually need. So if Medicaid is paying for 4 out of 10 births, it's systemic and it is a systemic bottleneck. Delayed care is dangerous care, but fixing this onboarding process through presumptive eligibility changes everything. Check this out. So, how does the Fast Pass actually work? And who gets to use it? Let's look at this map. The American healthcare landscape is divided into 3 distinct tiers here on my cute little map. First, we have the gray states. These are states that have not adopted broad clinic-based presumptive eligibility for pregnant women. They're not on board. So in these states, there is no fast pass. Uninsured mothers are forced to wait out the clock. And here is the psychological reality of the wait. Out of fear of devastating medical debt, many mothers simply skip their first and second trimester appointments entirely. They wait until their permanent Medicaid card arrives in the mail, all the while probably getting judged at the same time. So by the time they enter the clinic or hospital, they might be 20 or even 24 weeks pregnant. This delayed entry into care leads directly to higher rates of preterm births, NICU stays, low birth weight babies, and undiagnosed maternal complications. Next, we have the blue states, and I'm not talking about the Democrats. These states offer what's called hospital presumptive eligibility. Under the Affordable Care Act, all 50 states must allow hospitals to give out these temporary fast passes. But in these blue states, the hospital is the only place you can actually get that fast pass or enter the park. The local clinics can't do it. So let's break down this massive operational flaw. So mothers do not go to the hospital for a routine 8-week prenatal checkup. They go to a community health center. They go to a primary care doctor, right? So when do mothers go to the hospital? Let's think about that for a second. They go to the emergency room when they're bleeding, when they're cramping, when they're panicking, and when their gestation is far enough to warrant them having to go into the hospital for complications and monitoring instead of remaining outpatient. Because they don't get into the clinic until there is a crisis. So then, this is then, the emergency room doctor stabilizes them. The hospital administration onboards them into Medicaid via the HPE. We're incentivizing incredibly expensive chronic emergency room management instead of cheap preventative calm clinic care. So finally, we have our green states. You see them, they're beautiful, right? Them beautiful green states. We have about 30 of them, and Washington, D.C. have adopted this gold standard of broad presumptive eligibility for pregnant women. And it's beautiful. So in these states, you don't have to wait for an emergency to happen. You don't have to go to the hospital. You can walk into a local WIC office, a county health department, or a federally qualified health center, FQHC, and you're good. The receptionist can ask your household size and income and plug it into the state portal and print your temporary Medicaid card on the exact same day. You get your fast pass. You're seen at 8 weeks. Your provider builds a relationship with you, prescribes your vitamins, does your blood work, and seamlessly bridges all of the full Medicaid world with you before the 60-day temporary pass expires. So now I want to speak directly to the healthcare administrators out there. The clinic managers, the CFOs watching this video, because policy is just theory until you figure out how to operationalize it. And let me say that again, policy is just theory until you are able to operationalize it. What is operationalized is what actually happens. We can policy all day and night, but if we don't operationalize it, it ain't gonna happen. You're gonna be putting out fires all day long and fighting and all sorts of nonsense. So if your state allows for broad presumptive eligibility, your clinic needs to become a qualified entity or a QE. This requires a few operational steps. First, you have to train your front desk staff and your patient navigators. You have to learn the basic income screening thresholds, and you have to get secure access to your state Medicaid portals. But I know exactly what is holding many clinics back. And I know the CFO's biggest fear. You might be thinking, if my front desk staff acts as a qualified entity and hands out these fast passes, what happens if the state later decides that the patient doesn't actually qualify for Medicaid? See, did I address the elephant in the room? What if they made a mistake on their application? Am I stuck with the bill for those ultrasounds and those lab tests? The answer is no. You're not. The answer is no. And this is the most brilliant under-discussed part of the policy. Under federal statutory guidelines, if you are a qualified entity, QE, a qualified entity or QE determines a patient is presumptively eligible in good faith. Medicaid guarantees reimbursement for the ambulatory prenatal care you provide during the temporary period. Let me say that again. In good faith, in good faith, if you take on that patient and you presume they're in good faith eligible for Medicaid, you run your tests, you get your vitamins, you do your ultrasounds, the labs, they pee in a cup, all of that stuff happens. You still get paid for it, even if that patient is deemed ineligible, I'm sorry, even if that patient is deemed ineligible for Medicaid. So I will say it again, Medicaid pays you for care, even if the mother's final full Medicaid application is ultimately denied. It completely removes the financial risk for providers. It stabilizes clinic finances and allows you to open doors to marginalized uninsured populations without risking uncompensated care or bad debt. So for those of you who are working inside, I shouldn't say you, for those of us who are working inside the healthcare machine, we often use a framework created by the Institute for Healthcare Improvement known as the Quintuple Aim, which if you've been on this channel before, you know I'm obsessed with the Quintuple Aim. It used to be the triple aim, and then it became the quadruple aim. Then finally it became the quintuple aim when they added health equity to it. It is the gold standard, in my humble opinion, of evaluating policy to see if it's actually working. I take it a step further than that. Evaluating your whole system, honestly, your outcomes, like what is actually happening, the experience therein. So the goal is to hit 5 targets simultaneously. They are: 1, first and foremost, better patient experience. It is better for a patient to experience good care, right? It's better for a patient to experience better outcomes like prevention of morbidity or cure of morbidity or the ability to mitigate those health complications, right? So better patient experience, better population health, lower costs. Yeah, you heard me, CFO. Lower costs, clinician well-being, which is huge, and health equity. Now, let's look at how presumptive eligibility doesn't just hit one of these aims and how it hits all 5. Check this out. So first, let's talk about patient experience again. Think about the trauma of navigating modern medicine, a medical billing. Imagine being a pregnant, hormonal, frightened mother who's told by the billing department that she has a financial liability, and there is a big, fat, juicy question mark at the end of that financial liability. So it's open-ended. You have no clue what it is that you're going to owe at the end of all of this, right? So now contrast that with a clinic that uses presumptive eligibility. She walks in, the patient navigator says, "Don't worry about the cost today. We have a portal. We're going to get you covered right now, and the doctor will see you in 5 minutes." Hmm. That sounds good to me. I don't know about you. The relief is palpable. And I myself have been in this situation. You're creating intense patient loyalty po and a positive trauma-informed clinical experience from day one. Again, first impressions go two different ways, right? It, First impressions make a huge difference, especially when you're talking about whole slews of the population who are dealing with trauma on a regular basis, like feeling like you're going to get accosted every time you incur cost in the healthcare system. Things like that. Like it's just insane. If we can have an experience that builds trust, that builds partnership, that is better for everyone involved, right? Like if the person at the front desk doesn't have to fight you, they're just like, "Here's your pass." You know what I mean? Like it's awesome. Like, let me give you this good news. Let me give you this good news. This good news is going to ruin your day, right? Nah. Second is population health. A landmark peer-reviewed study out of Tennessee looked at what happened when they launched this exact FastPass system. And this was Tennessee. The results were staggering. Listen closely. Pregnant women were 40% more likely to enroll in Medicaid overall. And that is opposed to being completely uninsured. Okay. They were 300% more likely to fill a prescription for prenatal vitamins in the first trimester. What? 300%? When a whole community gets early access to vitamins, and I don't even call this early, this is timely, okay? Because we already know what happens with folic acid and when we need to take folic acid, right? But gets access to vitamins and hypertension screenings, the overall health of the population transforms. It is called population health for a reason. So next, let's talk about lower costs and the return on investment. So if your organization contracts with managed care organizations or MCOs, you know how heavily they hit scores, HEDIS. These measure things like timeliness to prenatal care, right? Because if we can't measure it, if we can't if we can't measure it, okay. So this right here is a measurement for how soon we can get these pregnant ladies in, right? Timeliness to prenatal care. When you use presumptive eligibility or PE to get patients in the door faster, your quality scores actually go up and your state incentive payments increase. So there's actually money, money in the game. This is incentivized. So let's zoom out of the macro level here for a second. Standard routine prenatal care for a healthy pregnancy costs the state. Let's say it costs the state Medicaid program just a few $1,000s. But if a mother's preeclampsia goes unmanaged because she was stuck on a wait list, she delivers a baby at 28 weeks, then there might be a stay in the neonatal intensive care unit. You can easily exceed $75,000 to $100,000. And that's a single case. All right. So presumptive eligibility is the ultimate. Well, I'm not going to say the ultimate. Let me go back. Presumptive eligibility, it makes it rain in the ROI world. So preventative care is one of the greatest cost saving measures that we actually have. Let's talk about the fourth part of the quintuple aim. Clinician well-being. Again, in healthcare administration right now, we talk constantly about burnout and moral injury. Moral injury happens in healthcare when workers know the right thing to do, but systemic barriers prevent them from doing it. Let me say that again. Moral injury happens when you know the right thing to do, but systemic barriers prevent you from doing the right thing. How I'm a nurse, so I can speak as a nurse and only as a nurse, right? That's the only place that I'm saying. How many times have I remember being in nursing school and we all go around and we say why we decided that we wanted to be nurses. And like everybody in the room and their mama's like, oh, I want to help people. I love helping people. I love helping people. Because we did. We do want to help people. Yeah, right? But then you go through school and all that rigorous training, and then you go through your clinicals and whatnot, but you're still not the bubble still hasn't popped. Like you're still given a censored version, a censored reality of what it's like to actually be out independent as a nurse at the bedside, right? You finally make it to bedside, and if you're lucky, you might have some sort of residency program or training program for new nurses where you're still a little insulated, or you might have a prolonged training period where you're still a little insulated. But then eventually that ends, right? You can only be a novice, remember the continuum, right? You can only be a novice for so long, right? Then the real world hits you. The system hits you. The folks who are trying to juggle the reality between or juggle the delta between nursing school and I just want to help people versus the operational constraints and the system and the red tape and the bureaucracy, like gosh darn, I just wanted to give this patient Tylenol, right? but um but yeah, that contributes to burnout when you're just like, I want to make progress. I want to catch traction and move forward. I want to move this forward for my patient, for my community, for my population, for the folks that I work with, for my homies in the trenches. I want to move this forward, but I can't. I can't get traction. Burning out, I burn out my wheels. And that's what happens. That's what happens. Or you end up having to make decisions. Actually, I'm not even going to go there, but some people have to make decisions that go against, or some people make decisions that go against, um, their ethos, essentially. I mean, I'm not talking about me though. But anyway, so moral injury happens in healthcare workers when they know the right thing to do, but systemic barriers prevent them from doing it. And I promise you, no front desk receptionist, no triage nurse, no doctor wants to look a pregnant woman in the eye and tell her to go home because she doesn't have insurance. Nobody. It destroys the morale of the staff. And that is also assuming that this pregnant person in front of you is perfectly healthy and is not experiencing any sort of symptoms, discomfort, morbidity, exasperation of any chronic conditions that the general population has. And we keep forgetting that pregnant people are part of the general population. We keep forgetting, right? So the prevalence of diabetes, the prevalence of hypertension, the prevalence of COPD, the prevalence of all of these these chronic conditions, right? They don't go away when you become pregnant. In fact, pregnancy is considered what? The stress test, the ultimate stress test. Okay. So yeah, in the situation where folks have to turn patients away, and I have I have seen this firsthand, making calls for patients myself to get them seen who do not have insurance to get them seen, jumping through hoops in some of these states, even some of these green ones. I'm not even gonna lie. Let me tell you, let me tell you, not a single time that I had to jump through hoops was the mother completely healthy and without complication. So let's just put it that way. We're not just talking about like a member of society that's healthy. We're talking about a member of society that is carrying the future of society literally in their bodies. So when you equip your clinic to be a qualified entity, you give your staff a superpower. You empower them to say yes, which is exactly what they want to say, right? They want to say yes. You give them the tools to actively solve the patient's problem in real time, which deeply protects clinician and staff well-being. And finally, the fifth aim, which is health equity, not equality, equity. We can't discuss maternal health care without directly addressing the staggering disparities in this country. And I'm referring to the United States. And we must look at the concrete numbers. According to the CDC, Black women in the United States are nearly 3 times more likely to die from pregnancy-related causes than white women. The maternal mortality rate for Black women is roughly 69.9 per 100 live births, and we only count those with live births, okay, compared to 26.6 for white women. With Indigenous and Alaskan Native women, it's over 2 times more likely for them to die of pregnancy-related causes. Furthermore, when we look at insurance access in early pregnancy, Hispanic and Latina women face some of the highest rates of uninsurance prior to conception, often hovering around 27%. The numbers aren't like these numbers are biological and they're not inevitabilities. They are the result of systemic and structural design and barriers, right? This is just what happens. The 45-day Medicaid waitlist acts as a financial gatekeeper that disproportionately locks out those who are Black, Indigenous, Hispanic from receiving first trimester care. Let's talk about presumptive eligibility as a structural equity tool. It bypasses the systemic barrier completely. It circumvents it, right? It ensures that the moment a mother knows she is pregnant, regardless of her race, regardless of her background, regardless of her bank account, she is guaranteed immediate entry into the healthcare system. So policy can feel really abstract. And this video was not really about policy per se. It's more about systems and it's more about this system that pregnant women or people prenatally have to navigate. And we also know that it's not just a pregnant woman that is navigating the system, but it's the pregnant woman's support system, the pregnant woman's family, the pregnant woman's neighbors, of pregnant woman's community that really that bat the blows of all of this, right? So yeah, policy can feel abstract. It can feel really academic until it happens to you or it happens to someone that you love. I'm one of those people, and you're probably one of those people too, where, and I've said it a million times, if somebody does something to me, that's one thing, right? I can forgive or I can work through it or whatever. It's different when someone wrongs or something goes amiss with someone that I love intensely. Uh, in this example, it would be a child, right? And I'm not saying that I'm not presuming how people feel about pregnancies and whatnot, but um, I think it's worth remembering that this stress of navigating this system, the residual effects of having a mother who is like, I'm sorry, mothers are the cornerstone of society, right? But having a mother um, under this stress and without presumptive eligibility, uninsured, unable to access maternal health or prenatal care, or even like I'm not even talking about the ones without insurance, but like when there is I want to say conflict, but that's not the word. That's not the word. When it is not possible for a patient to experience better outcomes or to access basic care, it doesn't just affect the patient. It affects the entire family. I remember in my own case, I struggled with hyperemesis gravidum, right? Um, and it was pretty bad. I was managed in the emergency room for majority of both of my pregnancies because I couldn't hold anything down, and I had insurance. It wasn't like I was on Medicaid. I had insurance. I had private insurance, but I still could not access care. So again, solving the issue of insurance isn't a catch-all, right? You're just giving, when you solve for insurance, you're just giving people a fighting chance, right? You're giving them a fighting chance. You are making it possible for folks to be a little better off at the end, to maybe have a better outcome. I'm not saying the best, but a better outcome than they would have if they did not have insurance or access to care. But I do remember personally how devastating it was not to have access to infusion therapy or hydration therapy, and the cost that the cost of going to the emergency room every week to get to get fluid resuscitation, like it was just insane. And what it's done to kidneys and whatnot, and knowing that my family had to watch me go through it. Because again, it's one thing for me to go through it, but it's another thing for my loved ones to witness me going through it because I couldn't pretend well enough and long enough that I was okay, evidenced by my child being evicted from my womb in the second trimester. So, anyway, it might feel abstract. This might seem abstract, but until it happens to you or someone that you love, I promise you. So, let's get back to Maya, our uninsured mother, sitting at her kitchen table, trying to get a doctor's appointment. Depending on where she lives and depending on whether the clinics in her town have done the work to become qualified entities, her story has two very different endings. In a gray state or a town that hasn't implemented this policy, she waits. She enters care in her third trimester, if she makes it to the third trimester, right? Through the emergency room. There's there's no paperwork done, there's no history, there's no nothing. This mother comes in with a blank slate, and we know what that's like when we have patients coming in coming in active labor, and they're ghosts in the system. We know nothing about them. And so all the king's horses and all the king's men are trying to gather this information that would have been actionable and left the mom and the baby and the family better off if we had it before. But now we're playing catch up at the moment of exasperation, of crisis, at the moment of birth, right? So her baby was born premature, spending weeks in the NICU. Her family is instantly buried in medical debt. Oh, I've been there. Months in the NICU will do that, trust. Okay. Her family is instantly buried in medical debt, and she suffers from postpartum complications that could have been prevented months ago. But in a green state, in a clinic that utilizes the fast pass, everything could have been different. She walks in, she gets her temporary card, bam, right? She gets early intervention, nutritional counseling, consistent monitoring. She delivers a healthy, full term baby. and her formal Medicaid application is approved on the back end without her missing a single doctor's appointment, or in that 60 days it is denied, but she still got her ultrasound, her labs, and was given time to actually navigate the payment structure, right? So prenatal care should not require a wait list. Access to a healthy pregnancy should not depend on your zip code. If you're a clinician, a nurse practitioner, a social worker, or a hospital administrator watching this, find out today if your clinic is a qualified entity, please. If you aren't, talk with your leadership, maximize your status, train your staff, and I can help you with that. When an uninsured pregnant patient walks through your doors, do not turn them away. Onboard them. And again, this is something that I can help you with. Okay. So reach out. So if you're a maternal health advocate or a doula or a concerned citizen living in a gray or blue state, look up your local state representatives and demand that they submit a state plan amendment to expand presumptive eligibility to community clinics. Mississippi just did it most recently in 2024. Your state can be next. The legislative blueprint is already there. We just have to demand that it is used. So thank you so much for giving me this time to dive into actual ground level policies that are shaping maternal health in the country. Feel free to hit the subscribe button. I put links to the policy tracking tools, the MACPAC guidelines, and the Tennessee data that I talked about here today right down in the description box below. Send this video to your clinic manager, send this to your state rep. Advocate for yourselves, right? Advocate for your patients, and I will see you in the next video.
Look out for new updates.